Understanding Systolic Anterior Motion and Mitral Regurgitation in Hypertrophic Cardiomyopathy, an echo-based prediction framework. In normal hearts, the septum is about 10 millimeters thick and the left ventricular outflow tract is wide. Blood flows unobstructed from the left ventricle to the aorta. In Hypertrophic Obstructive Cardiomyopathy, septal hypertrophy narrows the outflow tract. This creates the anatomical substrate for systolic anterior motion to develop. SAM occurs through drag forces, not the Venturi effect as previously thought. High-velocity flow through the narrowed outflow tract pushes the anterior mitral leaflet toward the septum. The leaflet is dragged anteriorly by flow momentum. Elongated leaflets are a key predictor of SAM. Normally, the anterior leaflet is about 24 millimeters and the posterior leaflet is about 14 millimeters, with coaptation far from the septum. In SAM risk patients, the anterior leaflet exceeds 30 millimeters and the posterior exceeds 22 millimeters. A reduced coaptation to septum distance places coaptation directly in the flow path. The anterior to posterior leaflet ratio determines where coaptation occurs. A normal ratio of 2.0 keeps coaptation posterior, safely away from the outflow tract. A low ratio shifts coaptation anteriorly toward the septum. A very low ratio of 0.8 represents high-risk geometry with excess posterior leaflet tissue in the outflow tract. Why do some SAM patients have severe mitral regurgitation while others don't? The key question is, can the posterior leaflet follow the anterior leaflet? If the posterior leaflet follows, the leaflets maintain contact, resulting in mild or no regurgitation. If the posterior leaflet cannot follow, a coaptation gap develops, causing severe regurgitation. Contact length is the strongest predictor of MR severity, with a correlation of -0.89. It directly measures whether the leaflets overlap or have a gap. Positive contact of 8 millimeters or more means a sealed valve. Negative contact, meaning a gap, creates a regurgitant orifice and severe regurgitation. The anterior to posterior leaflet length mismatch asks, can the posterior leaflet physically reach? Think of two people shaking hands. Both need long enough arms. If both leaflets are elongated, the posterior can reach the displaced anterior leaflet. If the anterior is much longer, the short posterior cannot reach, and a gap develops. Posterior leaflet mobility asks, can it move forward? Even with long arms, you cannot shake hands if your feet are nailed to the floor. A mobile posterior leaflet is free to follow the anterior leaflet. A tethered posterior leaflet, anchored by chordae, cannot follow, leading to severe regurgitation. Tenting area quantifies subvalvular tethering. Small tenting means minimal chordal pull, and the posterior leaflet is free to move. Large tenting creates strong pull that anchors the posterior leaflet in place. This explains why chordal cutting during myectomy helps reduce mitral regurgitation. The single question that determines MR severity is, can the posterior leaflet follow the anterior leaflet? 3 components answer this. Can it reach? Can it move? Did they meet? Each is measured by echo parameters with strong correlations to regurgitation severity. The key insight is that the LVOT gradient does not predict MR severity. The aorto-mitral angle acts as a launching pad for SAM. An obtuse angle aims the leaflet away from the outflow tract, which is protective. An acute angle aims the leaflet directly at the outflow tract, creating high risk. This angle helps determine if flow will catch the leaflet. The unified model shows that SAM predictors are not the same as MR predictors. SAM predictors ask, is the leaflet in the flow path? MR predictors ask, can the posterior leaflet follow the anterior leaflet? The posterior leaflet determines your patient's fate. Remember, SAM severity does not equal MR severity. Focus on posterior leaflet behavior to predict regurgitation.